gewoon nog leeft natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero, per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way, and most patients and relatives understand that we're also human and mistakes can happen, and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
Good afternoon, everybody, and welcome to this ESICM webinar on tissue oxygenation monitoring, applications, and outcomes. My name is Katia Donadello. I'm an associate professor in anesthesia and intensive care at the University of Verona, Italy. And I have the pleasure to moderate this webinar supported by GA Healthcare. And I will introduce the first speaker of this afternoon rendezvous. Dr. Tommaso ZOERLE, after a medical education and fellowship in Italy, spent two important periods of his education abroad, the first one in Canada at Toronto and the second one in Cambridge, England. He is at present a neurointensivist in Milan at the Ospedale Maggiore Policlinico, and he will talk to us about monitoring brain oxygenation. Tommaso, please, the floor is yours. Thank you.
Thank you, Katia. So, good afternoon. I have no conflict of interest, and today I'd like to speak to you about the rationale for brain oxygenation monitoring in neurocritical care patients. And I'd like to speak to you about the bedside techniques that are available for this aim. And I'd like to add a few words about treatment option. The rationale, we know that the oxygen is very important for the brain. And even if the brain represents only the 2% of the total body weight, we know that it accounts for the 20% of the oxygen consumption. Moreover, neurons requires energy for the function, but also for the integrity. And the glucose is the main energetic substrate for the brain. Unfortunately, we need oxygen to obtain the energy requested. In fact, with the oxygen, we can obtain a large amount of ATP molecules through the oxidative phosphorylation. For this reason, I think that it's reasonable to include the brain oxygenation monitoring in the multimodality monitoring for neurocritical care patients, and this could be helpful to detect second insults and to better understand what's happening to our patients. How can we do that? I think that the ideal brain oxygenation monitor should inform us about the brain perfusion, the brain vessels, and the oxygen content in the brain vessels. This is possible. In this work, the researchers used the two-photon microscopy to obtain in vivo brain cortex imaging and to map the PO2 in the brain vessels. However, these techniques, it's just for research and for small animals, but we know that we can obtain information at the bedside at the 3 different levels, and these information are very important. First, we can try to approximate the oxygen delivery to the brain. We know that the delivery is related to the cerebral blood flow and the arterial oxygen content. Unfortunately, the monitor of the CBF at the bedside, it's very difficult, but we can try to obtain the cerebral perfusion pressure. That is the difference between the mean arterial pressure and the intracranial pressure. And often in the neurocritical care patient, we have this data. Moreover, it's easy to calculate the arterial oxygen content. With a normal blood gas analysis, we can obtain this number that it's related to the hemoglobin and the hemoglobin oxygen saturation. These information are essential, they are basic, and they can give us information about the global brain oxygenation. But we can have more, and we can have information about the oxygen extraction from the brain. And this is possible using the SJVO2, the jugular bulb oxygen saturation, that it's related to the delivery, but also to the cerebral metabolic rate of the oxygen. We can have this number, and it's again, it's quite easy. We have to put a venous catheter at the level of the jugular bulb, and with a normal blood gas analysis, we can have the number about the oxygen extraction. If the SjVO2 decrease, it means that we could have a problem with the cerebral metabolic rate. For example, our sedation plan is not adequate, or we have problem with seizure or temperature. Or if the SjVO2 decrease, we could have a problem with the CBF or the oxygen arterial content that we know now that are related to the mean arterial pressure, to the intracranial pressure, cerebral perfusion pressure, hemoglobin, and gas exchange. The main limitation of these techniques is that, and it was shown in this study by Dr. Coles in Cambridge, is that if you look at the relationship between SjVO2 and the ischemic brain volume, we know that to obtain low values of SjVO2, we need that at least 100 mL of the tissue should be ischemic. So with this data, we have global information about brain oxygenation. They are more advanced compared with the ICP and CPP, but they are still very cheap. Finally, we can obtain information about tissue oxygen tension, and we can use a catheter placed inside the brain. With the PbO2, we can obtain a continuous monitoring of the brain tissue oxygen tension. And we have to think about the PbO2 as the oxygen tension at a level between mitochondria and the arterial capillary. The normal values are considered higher than 20 millimeters of mercury, but we have to remember that this is a very focal monitoring. From the physiology, we know that the PbO2 is related to local factors and systemic factors, but when we are at the bedside, it's important to remember that the PbO2 is indicative of the oxygen diffusion more than the oxygen delivery and the metabolism. This was shown by Rosenthal and colleagues in these elegant works. They studied 14 patients, traumatic brain injury patients, and they studied the relationship between the PtO2 and the CBF in different conditions. And what they show is that if you look at the PtO2, it is strongly related with the CBF and the PO2. We know that the PtO2 is a focal monitoring, and so the question is where I have to put it. And this is a difficult question in acute brain injury patients, because we know that TBI and subarachnoid hemorrhage are heterogeneous disease, where you can have normal appearing tissue or damaged tissue. In our center, we think that it's reasonable to try to put the probes in a tissue that is damaged but still recoverable. That's not always possible, and other centers think that it's better to put the probes in the normal appearing tissue. The important thing is to remember that the number of the PO2 are related to the tissue where I put the probe. And this was shown in this study, it's confirmed in this study, it's an experimental study. They explore the values of the PtO2 in different regions in an experimental model of traumatic brain injury in pigs. They put several probes in the pig's brain, one in the contusion, one very proximal to the contusion, one distal to the contusion, and one on the contralateral side of the contusion. And they show that in different conditions, what you have is that if you measure the PtO2 distal the contusion, you can have data very close to the probe contralateral to the brain contusion, but the numbers are different compared to the value that you can obtain from the probe in proximal to the contusion or inside the contusion. And we had in the patient similar results. In this study, Luca Longhi showed that if you put the probe in the perifocal tissue, you have median values of the PtO2 lower compared to the normal appearing tissue. And again, the percentage of time of the PtO2 that it's lower to the normal value of 20 millimeters of mercury was higher if you put the probe in the perifocal tissue compared to the normal appearing tissue. So the PtO2 should be considered as an advanced monitoring technique. It's a focal monitoring and it's expensive. For the treatment, we know that we need a proper interpretation of this data if we want to try to target the therapy for our patient and to try to give to the patient a better chance of a good outcome. This kind of approach was proposed in this study, the BOOST-2 trial, where the research randomized the patient to different interventional protocol. The first group of patients was treated based on the standard ICP guided protocol. The second group of patients was treated with a protocol considering the ICP monitoring and the PTO2 monitoring. The results showed that this kind of approach is safe, and they had good results also in terms of outcome. Now the BOOST-3 trial, it's ongoing, and I think that in the future we could have positive results from this kind of trial. However, if you look at the protocol, it's quite complex. This is the protocol proposed for the BOOST-2 trial. And if you are interested in this kind of approach, probably it's better to look at this recent paper. It's a consensus. Most of the authors from the BOOST trial are included in this consensus. And you can have algorithms that I think that are more clear than the original protocol. However, in the urgent situation, I think that there are two important questions that we have to keep in mind treating the neurocritical care patient with an hypoxic brain. The first question is, could I optimize the oxygen delivery? And now we know that at the bedside, probably what we can do is to try to fix the systemic factors. That means that we have to think about the mean arterial pressure, blood gas analysis, intracranial pressure, cerebral perfusion pressure, and hemoglobin. In fact, it's quite difficult to obtain normal values of the PTO2 if your patient has a problem with the systemic oxygenation. This is a study where they explore the PTO2 level in patients with or without ARDS. And as you can see, in patients with ARDS, the PTO2 is quite low, but it's low because the gas exchange at the pulmonary level are very bad. The second question is, can I try to do something for the oxygen extraction? And now we know that from the physiology that the oxygen extraction is related to sedation, seizure, temperature, and we have to always keep in mind that patient could have a new ischemic problem. For example, in patient with aneurysma, subarachnoid hemorrhage, if we have a decrease in the PTO2, we can have some problem with the vasospasm. The last, we have a specific treatment for a low PTO2, and this is the normobaric hyperoxia. We know from different studies that if you use the normobaric hyperoxia, you have an increase of the PTO2. However, we are not sure about the significance of this data. Some studies suggest that if you use hyperoxia, there is an increase in the metabolic brain metabolism. Other studies show that there is no difference if you use or not use hyperoxia. I think that it's important that we have to remember that if you use normobaric hyperoxia, the PTO2 increases. So the normobaric hyperoxia, it's a good intervention to increase the PTO2. These are the last 15 patients that we studied in our center. And as you can see, the PTO2 dramatically increased during normobaric hyperoxia. However, it's important to remember that probably we are not increasing the local delivery of the oxygen. And we know this from the study by Rosenthal. They did different oxygen challenge, and they found that the PTO2 during the oxygen challenge increased. But if you think about the oxygen delivery, we know that during hyperoxia, the CBS do not increase. On the contrary, we have a slight decrease of the CBF. The arterial oxygen content increased a little bit. And at the end, if you do all the calculation, the local delivery of the oxygen do not increase. So we have to remember that hyperoxia, the risk of hyperoxia is to mask a problem. If we increase FaO2 during an hypoxic problem, probably we are just masking something important that is happening to the brain. For example, if we are during an hypotensive period, if we just increase the FaO2, we are not treating properly the patient. So in conclusion, I think that it's possible to say that oxygen is essential for the brain wellness. we can try to monitor the brain oxygenation at the bedside in ICU, and that detection of brain hypoxia episodes could be helpful in patient management. Thank you for your attention.
Dr. ZOERLE, thank you very much for your presentation. Our discussion will be displaced at the end of both presentations. And for the audience, for those who haven't done it yet, I might remember that you might send your questions, comments, and arguments either on the ESICM Web TV or in the SICM Facebook channel or on the ESICM YouTube channel, so that I might receive them thereafter, and we will increase the amount of discussion. Now I will introduce the second speaker of today's webinar, Professor Robert Thiele. He is Division Chief Critical Care Anesthesiology at the University of Virginia in the States. His clinical practice is focused on cardiac anesthesia and critical care. And thanks to his background in technology and biomedical engineering, he is devoted to advanced patient monitoring, including the use of near-infrared spectroscopy. Now he will discuss with us the monitoring tissue perfusion in high-risk perioperative setting. Professor Thiele, please, the floor is yours. Thank you.
Thank you very much. So I'm Bob. I'm a cardiac anesthesiologist and intensivist at the University of Virginia in the United States. And I am going to talk about regional oxygen supply, how to measure and monitor in high-risk patients. Some disclosures: I have had funding from the University of Virginia where I work, from the Society of Cardiovascular Anesthesiologists, from the NIH, the NIGMS, NIBIB now, and then Apple. And I've done some consulting work for companies in the space of oxygenation, both cerebral oximetry and pulse oximetry. So what problem are we trying to solve? Well, we're trying to prevent, in many of our patients, stroke, perioperative stroke. That's a uncommon but more common problem than we realized. A significant number of patients have what we call occult strokes now. So this is brain ischemia detectable on MRI without a clear clinical stroke after the surgery, or without a clear neurologic deficit. But the people that have tissue ischemia detectable on MRI actually do worse than people who don't, even if they don't have any signs of stroke. Regional oxygenation is really, I think of that as kind of measuring oxygenation outside of the brain. Tommaso talked about techniques for measuring oxygenation in the brain, but there are other organ systems that we care about, and that can be a little bit more difficult. So I'm going to talk about why, and then some of the options that we have. So why not just look at pulse oximetry? Well, obviously pulse oximetry only looks at the content of arterial the saturation of hemoglobin in the arterial bloodstream, which doesn't really tell you a whole lot about the level of the tissue. And that's because each organ auto-regulates, and each organ may have its own need for blood pressure and oxygenation, and each organ has its own consumption of oxygen. And also, in my space of anesthesia and surgical critical care, we have anatomical problems where even if the pulse oximetry, even if the arterial saturation is 100%, if you're not getting blood to tissue, then you're going to have ischemia. And so and then now also with the growing use of ECMO, both in the United States and around the world, it's even more important to really understand regional oxygenation. We certainly use a lot of it. We used a lot of it before COVID, and we're using it even now after COVID a lot more. And the technical solution to a lot of this is near-infrared spectroscopy, but there are other options as well. So NIRS is a window really thought of as a window into the brain or any tissue. So the absorption of near-infrared light can be described as a concentration of some chromophore, something that absorbs infrared light, its scattering coefficient, and the path length. And this can be used, you can create a set of equations that will then allow you to calculate tissue saturation as long as you have 2 wavelengths of light. So you need 1 wavelength of light for everything that you're measuring. And it essentially measures the redness, just like the pulse oximeter does. It measures the redness of tissue by comparing the absorption of red light to the absorption of infrared light. There are other things that you can measure as well, which are not available clinically. We study like looking at cytochrome oxidation states. But for the purposes of this talk, we're really only talking about oxygenation. And so the brain I bring that up because even though we'll talk about other things or other organ systems or other areas for this technology, the brain is what most people are familiar with, at least in the United States, for tissue oxygen monitoring. And we use in cardiac anesthesia, cerebral oximetry pretty heavily, where we put these patches on and they shine red and infrared light into the brain through the scalp and the subcutaneous tissue in the bone, and then absorb it or detect it some distal location 2 to 3 centimeters from the light source, and using those equations that I described can actually measure an estimate of tissue saturation. Now, this is not a absolute measure of saturation of oxygen in the tissue. It's a blended average of arterial blood, capillary blood, and venous blood. And just like PbO2, it's site specific. It's really only looking at the frontal lobe of the brain, or if you put it on the calf, it's really only looking at the calf muscle. And so one of the problems with using this technology, in particular in the brain, is that if pH changes or PCO2 changes, that can profoundly affect the arterial to venous ratio, which can change this number, even if the tissue saturation hasn't changed that much. And in hypothermic circle rest, when we're pumping blood backwards through the brain, then it's really confusing to try to understand what this number means. So it's not like a pulse oximeter where you can just slap it on and it means the same thing in everybody. You have to think about the physiology and understand that it's not an absolute measure, it's a relative measure. And so every patient is going to be different. So there's a lot of technology available to do this. Currently available are devices made by Nonin, Medtronic, Edwards, Hamamatsu in Japan, and Massimo. There's another device made called the Vioptics that's available, is FDA approved in the United States just for tissue monitoring and not for brain monitoring. So one question is, are they accurate? And kind of extending off of the previous talk, we use, or investigators have used jugular venous oxygen to sort of calibrate or figure out how close to reality these devices are getting. So this is data on the top right, looking at jugular venous oxygenation in ECMO patients, babies that are on ECMO, using a technology that was made by a company called CastMed, now owned by Edwards. And then with these children, they would give them a bolus of oxygen into their ECMO circuit and see if that would lift the jugular venous oxygenation or the NIRS measurement. And it turns out that they track pretty well. This is another study showing NIRS technology using comparing it to Lycox and jugular venous bulb oxygenation. So Lycox being the PbO2 or Clark electrode-based, very localized measurement of brain oxygenation. And what they found in this study was that NIRS was actually a little bit more closely related to the jugular venous oxygenation than the Lycox. And that's not surprising, as discussed previously. These PbO2 monitors are very localized. The jugular venous measurement is going to kind of represent all of the blood flow, or a lot of the blood flow from one side of the brain, which is essentially what NIRS is doing, just left or right frontal lobe when we're using it for brain monitoring. This is a nice study demonstrating how NIRS actually can be used outside of the brain. And we use it in our ICU patients quite frequently outside the brain, people that are on ECMO as an example. So this is a porcine cardiopulmonary bypass model. And they ran these pigs at different perfusion strategies, low and really low. So 48 cc's per kilo per minute of flow versus 35. And what we find is that in the group that the normal flow would be 60 cc's per kilo per minute. So in the top group on the upper right, you see that the perfusion, the flow rates dropped a little bit, like 15% or 20%. And you see the tissue oxygenation drop. And then when these animals go back to a normal perfusion strategy, it comes right back up. In the bottom right, what you see is what happens if you inadequately deliver oxygenated blood to an animal on cardiopulmonary bypass. So you have really low flow rate of 35 cc's per kilo per minute. And these animals don't really recover. You can't get their oxygenation back up. And this is all based on their tissue oxygen measurements, looking at muscles and not the brain. And that there's a lot of data in the sort of cardiovascular or perfusion literature that really does show that like you can detect inadequate inadequate pump flow or perfusion in the cardiopulmonary bypass or ECMO scenario can be detected by looking at changes in muscle oxygenation. So this is just an example of how we use it in the operating room. Looking at brain in this instance, on the left, you see cerebral sats in a patient that's on circ arrest, and you have a massive difference between the left and the right. And what we find is that in this case, there was a pretty big drop in the cerebral sats on the right when we went on circ arrest, and we had to fix that. So we actually had the surgeons change their cannulation strategy, had to use antegrade cardioplegia, or excuse me, antegrade cerebral perfusion, and that fixed the number. And this patient did quite well. It was very like some 80-something-year-old circ arrest case and had no neurologic deficits afterwards. You know, in the ICU setting, which is where I frequently work, it's interesting that we use a lot of this technology in the operating room, and then we take it off. And when we take it to the ICU, we should probably keep it on. In critical care, if you actually put oximetry devices on brains of patients after having surgery, they have 3 times as much hypoxia burden as they do in the operating room. And so I think this is a future opportunity for intensivists to really try to lower the perioperative stroke risk, because a lot of these patients are probably having their strokes in the first 24 hours after surgery, and we may miss some of that opportunity by not continuing to measure it. And it kind of seems irrational to put these devices on, pay for them, put them on for a 6 or 8 hour operating room case, and then just throw them in the trash when we could just bring them upstairs with them. But there are not a lot of people looking at this, and it's something that I hope we see in the future. In the ICU in particular, I think with our ECMO patients, this is quite helpful. You know, when you're not centrally cannulated and you have a ICU patient who's peripherally cannulated, you're not cross clamping the aorta, and you're not stopping the heart. And so you have really 2 pumps. You have the heart, and then you have the machine. And if the heart and lungs are failing, they're going to be pumping deoxygenated blood, which you can see on the right, out of the heart. And that's going to kind of go down towards the innominate and the right carotid and the right subclavian artery. On the femoral, typically femorally placed cannula is going to be pumping in completely oxygenated blood that's going to go to the left side of the brain, the left arm, and the lower extremities. And so if you're measuring oxygen saturation, for instance, a pulse ox on the left hand, you may miss profound hypoxia on the right side of the brain. And so we will use this in the ICU setting to measure cerebral oximetry on the brain when we have people that are peripherally cannulated on ECMO to help us detect cerebral ischemia. Now, in the ICU itself, we also use NIRS. Thinking outside the brain uses, we will use this technology. I showed those slides earlier about the muscle measurements in the pigs. We'll use it to detect ischemia in legs in these peripherally cannulated patients. So, with ECMO use going up everywhere, what you find is your surgical colleagues will cannulate the groin, and you're getting pretty good flows. But you have a problem in that the right foot is getting cold. And so how do you know if they need to go in there and put a distal perfusion cannula in, where they can actually perfuse blood, oxygenated blood, past that insertion site? And you can do physical exam to try to figure this out, constantly look at the foot and feel it, measure the temperature, but that's time consuming, and it's not a continuous monitor. And so there's a nice little study done a couple of years ago showing actually that if you just put sort of these tissue oximetry measurements, and I showed the list of devices earlier on both calves, and there's a different, either the tissue sat is less than 15%, or there's a 15% difference between the legs. That's basically 100% sensitive and specific for clinical signs of ischemia. So that doesn't mean they need to have that cannula necessarily, but it means that you would have detected something on your physical exam, and it's worth probably calling a vascular surgeon or calling your cardiac surgeon and see if they want to put that cannula in. So there's a nice analysis of the use of NIRS in peripheral tissue monitoring. I talk a lot about cerebral oximetry because it's what we do in the OR, and that technology is the same, but there's a growing use of this to measure other tissues. And really the 2 sort of main uses in our perioperative patients right now are outside of the ECMO sort of cardiac world would be looking for compartment syndrome in patients that in the lower extremity of patients that have lower extremity trauma or orthopedic surgery, and also as a surveillance tool for the detection of free flap failure. And that was what the Vioptics device that I mentioned earlier is really designed to be used for. One of the things you have to keep in mind is that these devices are not they're not absolute monitors. So if your hospital picks, let's say, the Masimo device to use, the cutoffs for your tissue saturation are going to be different than if you use the Edwards device or the Medtronic device or the Hamamatsu. So there's some local specificity there that you have to keep into account. And these devices are all different. They use different algorithms. Wavelength selection is absolutely critical. The more wavelengths you have, the more accurate they are in general. This is just some work from our own lab, looking at using the Vioptics device and then a 3-wavelength device that we built, which really did show in a forearm ischemia model where you put a blood pressure cuff on the arm and progressively make it ischemic. That the reliability of a 3-wavelength device in our lab outperformed the 2-wavelength device. Something that we've really started to realize recently is that some of these devices are pretty susceptible to skin tone. And so it's a lot of the data, for instance, in Matthias Herringling's trial showing that low oxygen cerebral sats prior to heart surgery was a predictor for bad outcomes. That was done in a pretty homogeneous patient population in Germany. You bring that to a country that or an area of the world where you have a lot of different sort of heterogeneous patient populations with different levels of skin tone, you get very different baseline numbers. And so there is probably some interference in some of these technologies from melanin in the skin that is an absorber of red and infrared light that you have to be aware of. And so it's worth, whatever you pick, kind of looking into literature and seeing how they perform. The left is one device, the right is a different device. They have different performance characteristics, different number of wavelengths, different wavelengths selected. So before I go to my conclusions, the last thing I would just say is that this is pretty technologically focused, but there is actually some interesting emerging data now that there are some devices coming out that are measuring capillary refill time and doing it in a systematic, automated way, which is something that I think you'll see increasing use of. People always used to talk about, perfusion of extremities, and this is a talk about perfusion. Looking at like capillary refill time has been very unreliable over the course of history because it's very user dependent. And so now there's been the development of some automated algorithms and devices that are not widely available, but there's some interesting data coming out that you can use quantitative capillary refill to guide, for instance, resuscitation and sepsis. And I think of that as analogous to train of 4 at least in the United States. It used to all be sort of qualitative. The anesthesiologist would feel the hand, and now we have these quantitative numbers that are monitors that are continuous and much more reliable. And the last thing that I would just mention is, and again, it's not technology, but it's worth thinking about, is the CO2 gap. That's become pretty interesting. The idea being that if you have an ischemic part of the body, and there's no blood flow going in there and there's no coming out, you're not going to detect hypoxia because the circulation is isolated. But CO2 is highly diffusible. And so those cells that are ischemic are still going to be pumping out CO2, which will diffuse into the rest of the circulation and will lift that venous CO2 number. And the gap between the two, arterial and venous CO2, is somewhat sensitive to sort of occult ischemia. You're looking for a number of 6 millimeters of mercury or higher. And that's something that, again, it's not really a technological thing, but something to always keep in the back of your mind for your armamentariums. So concluding, stroke, big problem after surgery. NIRS is a non-invasive estimate of tissue oxygenation. It is a local estimate. It measures the frontal lobes of the brain. If you put it on the head, it can measure muscles wherever you place it. It can't get into deep structures. It can't get the cerebellum. It can't get the spleen. In babies, it can get the kidney during pediatric cardiac surgery. It is a very accurate trend monitor. It is not an absolute number. These devices that we use for measuring regional oxygenation are all different. They use different wavelengths. They have different numbers of wavelengths, and they have different performance characteristics. And outside the operating room, the main uses for this technology, in my opinion, are in ECMO, which we use them all the time now, and in our surgical ICU for patients we're monitoring for sort of flat perfusion and also for compartment syndrome. Thank you.
Thank you very much, Professor Thiele. And thank you again, Dr. ZOERLE. So waiting for the collection of all the different questions, I'd like to start with some for the both of you. So I'll ask something first to Tommaso. You just highlighted the different techniques that we might be using for the monitoring of neuro patients. But what do you usually use routinely in your ICU? I mean, what do you usually place on your patients?
Usually, for all the patients, we use the basics monitoring techniques. So mean arterial pressure, there is no reason to don't use it, and saturation and blood gas analysis. For the comatose patients, usually we use PTO2 and SJVO2, both of them, because I think they can give you complementary information, and there is no reason to don't use them. In the comatose patient, we don't like to make a hole in the brain of the patient if there is no reason to do that. But in the TBI patient, GCS less than 8, usually we use SJVO2 and PTO2. And we don't use the NIRs.
Okay. So I have a question from the audience for you. So PbRO2 values increase exaggeratedly with hyperoxia, reaching arterial PO2 levels in apparently healthy tissue, more than 100 millimeters of mercury in your slide. How is this phenomenon explained, taking into account that there is an oxygen extraction of 30–50%?
Because you are just measuring at the capillary level. It's not the same values between the PTO2 and the PaO2. They tend to be similar, and you are just measuring the oxygen tension, not the oxygen content. So if you increase the tension in the arterial, you have an increase of the tension at the capillary level.
Okay. I have another question for you. I hope I will be able to reading it properly. According to your study, PbRO2 increases with normobaric hyperoxia up to 100 millimeters of mercury. As we know, NIRS values with hyperoxia remain at venous levels with practically no significant increase. I want us to imagine together the form of oxyhemoglobin dissociation curve in the end of cerebral capillaries with hyperoxia. I might breathe on your behalf.
Yes, it's too long.
I read it again.
Yes, slowly, and we can try to do
okay.
step by step.
Okay, so PbRO2 increases with normobaric hyperoxia up to 100 millimeters of mercury. Yes. As we know, NIRS values with hyperoxia remain at venous levels with practically no significant increase. I want us to imagine together the form of oxyhemoglobin dissociation curve in the end of cerebral capillaries with hyperoxia.
I'm sorry, I didn't understand the question really. I don't know if Prof. Thiele can help.
I mean, I think what they're getting at is like a physiologic question, which would be why, when the PbO2 goes way up, do you not see that in the NIRS? And, you know, I think as I think through it, I think the answer is that, you know, well, when I think about the bloodstream, you know, if the saturation of hemoglobin is 97% or 99%, that's almost no change at all in the actual amount of content of oxygen, right? Because most oxygen is stored on hemoglobin. You can make the PO2 in the blood 400, and it hardly has any effect on the amount of oxygen that's actually traveling to tissue. And so it doesn't really move the needle a whole lot if you have an increase. If you just move PO2 of blood up, you don't really change the actual oxygen delivery a whole lot, which is why you wouldn't see much of a change in the venous oxygen saturation on a NIRS device, because that's actually measuring it's 70% or so of the NIRS number is really going to be hemoglobin saturation in venous blood. That's how I would think through that. I think that's what they were maybe asking about.
Okay, thank you. And Professor Thiele, is there a place for NIRS in detecting spinal cord ischemia during or after endovascular aortic procedures?
Yeah, no, that's a good question. Not that I am aware of. I mean, you can't really, well, you certainly can't measure the spine. We talk about optical windows with NIRS. You got to be able to transmit that near infrared light into tissue, and it will go through bone, but not all the other tissue that's in the way of the spinal cord. So you certainly cannot use it to measure the spinal cord directly. It's an interesting question of are there surrogate areas where you could detect sort of ischemia that might tip you off to inadequate blood flow to the spine? And I've never really attempted to do that. We've thought actually about trying to put these, or we've actually in animal models, we've put these devices on catheters that we could insert. And there are, like you could have a splanchnic NIRS device as an example that would tell you that there was inadequate blood flow to a certain sort of abdominal region, which might tip you off that there was a problem in perfusion of the spinal cord. But that's not something that's available right now. But we've also thought about putting them on our echo probes, where the lower esophagus really tells you a lot about perfusion in this splanchnic vasculature, and would that be a useful device in the operating room to sort of look at perfusion outside the brain? But there's nothing that's available now that can help you do that.
Okay, and would you? It's quite difficult, probably, or not completely appropriate, but somebody is asking you, Professor Thiele, which one of the several available NIRS monitors would you recommend for monitoring an ICU patient in a NeuroICU?
Yeah, I don't. I'm reluctant to make any device recommendations. So I think there's that would be. I don't want to violate any conflict of interest rules. And what I would say, though, is that a recommendation would be to bring in the people that represent these companies and do your own due diligence on the technology. There used to be, I can say this, in the United States, there used to only be one technology. And now we have, I think, 5. And they are different. And they're different costs, and there's different performance characteristics. And so that data is not hidden. There are people out there like Hilary Grocott in Canada and the groups in the UK, Matthias Herringlake in Germany, who are really studying these things, and they're publishing their papers. So you can look this stuff up and figure out which ones you think are most accurate. The place I would start actually is Philip Bickler at UCSF, that group. The UCSF anesthesiologists have published some really good papers on how these different devices function. That would be my recommendation.
But do you believe that some of these devices have a different capability of detecting the tissue saturation on the different part of the body? I mean, do you believe that different technical properties of the specific device may enable one of them to be more appropriate for a brain or more appropriate for the limb or for the flap compared to others?
Yeah, they're not. Most of the devices on the market are really designed for the brain. The only exception to that is the Vioptics device. There used to be devices that were available for thenar muscle measuring, but they're not. I can't find them in the US anymore.
No, they are not available anymore.
Yeah, so that was a phase. That's over, a fad. But the wavelengths do matter. Like longer wavelengths are going to have better tissue penetration, and you can have farther source detector separation. But because nobody's really targeting muscle monitoring, you're not seeing that. I mean, in theory, you could say, if you were designing something just for muscle, you'd say, I want to have a little bit longer wavelengths, and I'm going to put that I'm going to separate the light source and the detector a little bit so I can get deeper into the tissue. If you remember that slide I showed with how it kind of works on the brain. But they're not doing that right now. They're really just focusing on the brain. I think that's an opportunity for sort of development of this technology.
Okay, thank you. And I believe this is for the both of you. So in low middle income countries without these sophisticated gadgets and performance status, what could they do or could they use to get similar outcomes?
Well, I can start by saying that that the quantitative capillary perfusion data I kind of referred to at the end, I don't have any slides on it, is actually really intriguing. There was a pretty large randomized controlled trial that was just published showing a signal towards superior outcomes in septic patients using that standardized capillary perfusion outcome as a therapeutic endpoint as opposed to lactate. I think it was 400 patients in that trial and 200 or so in each arm, and the p-value was 0.06 for survival. So not quite, not quite statistically significant, but a pretty small or medium-sized trial. And so if that's repeated, that's a space to watch because that's going to be relatively inexpensive. Of course, lactate and CO2 gap, in my opinion, I view lactate as like a screening tool. If it's elevated, then it's pretty sensitive for ischemia, but it's not specific. There are a lot of other reasons to have a high lactate, but now that combined with the CO2 gap, I think can give you even more insight into whether there's some tissue bed that's ischemic that you're not picking up on your physical exam. But so, yeah, like Tommaso said, just the basics, the hemodynamics, and maybe those two additional options, the quantitative capillary perfusion and the CO2 gap could be, I think, quite helpful and not expensive.
Dr. ZOERLE?
Yeah, I think for the systemic oxygenation, the basics, and for the brain, I don't think that SGVO2 is so expensive. Probably it's good also for the middle income countries, just a central line. So it could be useful and not very expensive.
Okay, now I have from ESICM TV. So I read it because it's quite long. So thanks. In our ICU at Case Hospital, Kampala, Uganda, EPET CO2, entitled CO2, and whose oximeter. Pulse, I suppose it was a pulse oximeter. What could be the best in patient monitoring? And I suppose that this part of question you have already answered to that with what you have just said. Then this person says, I strongly disagree with the recommendation about veno-arterial PCO2 for tissue perfusion monitoring. It primarily reflects changes in cardiac output and dissociation of CO2 from hemoglobin. As shown in experimental and clinical studies, veno-arterial PCO2 is a mislead surrogate for tissue perfusion. You indicated that acid-base, oh my God, I'm sorry, gas exchange always gives a slight different analysis with that seen on cardiac monitors. Any recommendation for limited resources?
I would, I'm not just, well, to back up, there's a couple things in there. I would say there is data on using this CO2 gap to actually detect ischemia in the specific organ beds in animals where they actually cause ischemia and measure this number. And I understand that it also is reflective of global hemodynamic changes, but it is also true that if you make a foot of a dog or something ischemic, you can, in a controlled environment, you can actually detect that. It doesn't tell you where it is, but so I would just say to the listeners, you got to do your own diligence and look these papers up and come to your own conclusions. And the last question, though, was about low resource countries and what?
Using about the indication of using blood gases, acid-base analysis that gives different analysis with that seen on cardiac monitors. So if it is feasible to use ABG instead of cardiac monitors in low-income countries?
Yeah, I mean, I would say from the ABG, the two useful values are the lactate, if you can get it, and then the base deficit. We know that with ischemia, probably about half of the base deficit is from lactate, and the other half is from unmeasured acids that we don't measure that also accumulate during ischemia. So I do think it's useful. I would say though, I don't know that ABG is less expensive than cerebral or tissue oximetry. I mean, the cost, at least in my hospital, of doing a blood gas is not that low. But everybody's got their own contracts with companies, and but I'm not necessarily convinced that serial ABGs is cheaper than putting on a couple patches that last for 4 days, as an example.
Tommaso, do you have something to add?
No, not really.
Okay, I have a question for the both of you, probably just to sum up something that appeared in your both conclusion. So both for PTO2 and for STO2, the word trend has appeared in your conclusion. And I believe that the punctual value of the recordings that may be performed by this device may be highlighted as less important than the trend that we might record during our patient evolution. Am I right?
Yes, I think the absolute values for every monitoring, it's important, but it's the trend that probably it's really informing about what's happening to our patient, the response to the treatment.
And when you decide the position of the PTO2 probe, as you highlighted that the fact of being within or nearby the lesion or far away from the lesion may provide you a very different value. What kind of absolute value would you consider the value that you expect when you are putting the probe and when you are treating the patient to correct the value? I hope that I was clear within the question.
I think there is no value that you expect. You expect a good value, even if the probe it's in the it's near the contusion or in the ischemic tissue. It's not important the value. It's if you have a low value in the normal appearing tissue, probably it's a big problem. It means that even if the tissue it's not directly damaged by the trauma or by the hemorrhage, you have a problem in that it's probably a global problem. If the value that you are measuring is low near the contusion, for example, probably you can accept a lower value. If you are trying to do everything that it's possible to do to increase this number, but it doesn't increase, and you know that you are very close to the contusion, at some point you can accept this number and say, okay, I am in a bad region of the brain, it's damaged, I cannot do more for this tissue. But it's quite difficult to decide where to put the probe. Theoretically, in my opinion, it's better to try to be very close to the damaged tissue, but sometimes it's not possible. You cannot ask the neurosurgeon to put exactly in that point a small catheter.
And Professor Thiele, when you were talking about STO2 on limbs, you use two different number values, below 50% or a difference of 15%. Would you suggest to the audience to use those values with the different available device as regional oxygen tissue perfusion or saturation, or do you suggest to stitch to the manufacturer values or to the old values on trauma patients?
Yeah, I would say that I believe that was a Somanetics study, which is now owned by Medtronic. That was a lot of the perfusion literature is using that 2 wavelength device. So, if you're using that piece of technology, I think then that 50% is a reasonable, or 15% difference between legs, or less than 50% absolute is a reasonable cutoff. But Tommaso said it too, like anybody, trends are so important, and I think more important than absolute values. And that's probably true even for like blood pressure and oxygen saturation. And these people that live at like 92% don't need a SATA 100% when they're in the hospital. And people that have a normal blood pressure map of 100 probably need to have higher than a map of 65 millimeters of mercury when they're in the OR and the ICU. And that concept holds true both for like the common things that we do and sort of some of this newer advanced technology. So I do think that cutoff, those cutoffs are a reasonable first sort of estimate of how to guide your care if you're using that particular technology. But if you should still, you'd want to have these, ideally you'd have these patches on before you do the cannulation, so like where your starting point is. That is one of the nice things about, at least in the ICU, using them for laterality, is that if you use a different piece of technology that's not the somanetics, let's say that the normal would be 70% for some other technology, you will detect a difference between the sides. And that's why that 15% difference is so important and device agnostic.
Thank you. I have another question for Tommaso. High PbRO2 values with hyperoxia can mask ischemia. Does this mean that oxygen is not the most important element in brain metabolism?
No, that means that we have to think about what's the number, the information that it's related to the number. So I show you in one of the last, at the end of the presentation, that if you increase the PTO2 with the hyperoxia, you are not increasing the oxygen delivery. That's the point. If you use hyperbaric hyperoxia, probably you can increase the oxygen delivery. But with normobaric hyperoxia, you are just increasing the oxygen tension, but you are not increasing the oxygen content in the blood. That's the big point. For sure, the oxygen is important in ischemia. If we can have a normal oxygen, probably we can resolve ischemia. But the point is that the PTO2 with a very high level, it's indicative that you have a high oxygen tension, not a high oxygen content.
Okay. May I just ask you something that probably is done for sure? Whenever you are talking about oxygen dynamics within the brain, I suppose that you are talking about a patient who is absolutely normocarbic, right?
That's right. Is that for Tommaso? Yeah.
It is for the both of you. I mean, because we are talking about tissue and cerebral oxygenation, and CO2 has been left on a corner. But I believe that whenever we are talking about oxygenation and perfusion, the action of CO2 on brain and tissue, mostly on brain vessels, is of absolute importance. So if we are talking just about oxygen, I believe it is fundamental to state that we are talking about a situation where CO2 is normal.
Yeah, I agree with that. I mean, I think one of my slides showed the EDO data from Japan, just showing what a profound effect altered CO2 can have on brain blood, or on sort of the compartmentalization of blood in the brain. And so, yeah, at least in my world of the cardiac anesthesia and ICU, we work very hard to keep CO2 normal. And we have pretty exquisite control of it with mechanical ventilation and or ECMO.
I think not always. For example, for acute brain injury patients, sometimes we use hypocapnia and hyperventilation for ICP control. So sometimes the PTO2 or the SJVO2, it's used as a monitor for this aggressive treatment. If the brain oxygenation decreases during hyperventilation, some people suggest to come back from extreme hypocapnia, but usually we are keeping Normally, yes, sometimes it's used for the...
This is where I wanted to get to the fact that these two elements have to be always depicted together in order to clearly understand the picture of the brain. So we are at the end of this rendezvous, and I really thank you both to be part of this event and this experience. I thank the audience, and I've been delighted to moderate this session. So thank you very much to everybody, and take care.
Thank you.
Thank you.